My name is Aruna Arora. I'm the president, and I'm here today with two guests from the Alabama Department of Public Health. We have Dr. Karen Landers, our Assistant State Health Officer, and we have Dr. Wes Stubblefield, who is the new District Medical Officer for the Northeastern and Northern regions of our state. And they are both experienced pediatricians in addition to their roles with the Public Health Department. So Dr. Landers, I'll go ahead and start with you for a COVID update.
Yes, thank you. I wanted to make sure that I was unmuted. The most important aspect of talking about COVID-19 in Alabama right now is that we do see a decline in our overall numbers of cases, along with our overall percent positivity and hospitalizations. But this is not a cause for celebration. It is certainly a cause for our being happy that this is going down, but COVID is not over in Alabama, and we need to continue to keep our vaccine rates up, as well as to continue our mitigation standards. Just real quickly, our data is on our data and surveillance dashboard, but if we look on a daily basis, we had about 1,700 cases. Today, our percent positivity is a little over 12% of our tests that are being run, and our hospitalizations have been around 1,300. So again, those are causes for us to be happy, but not causes for us to celebrate. If we look at the trend of why we're having less COVID right now, well, obviously we have had a lot of COVID disease, so now that accounts for our having less overall, because a lot of people have had COVID. We also have had an increase in our vaccination, certainly not to the level that we had this past spring. We do know that we will see some decrease in hospitalizations, regrettably, because people have died and have left the hospital that way. But we also have seen this cycle in Delta, specifically in other countries, as well as other states in the United States, where Delta started activity in Alabama about June, and then certainly increased in trajectory, and now we're starting to see this decline. But again, we remain in high transmission, which means a percent positivity of greater than 10%, equal to or greater, and greater than 100 cases per 100,000 population. Now, a lot of people ask the question, well, when can we just abandon mitigation and go back to doing everything we were already doing? Keep in mind that once you get out of high transmission, and we have a very transmissible variant here, you still are looking at substantial, moderate, and low before you really get to where you want to be, which is low. So I would certainly urge people to stay the course with us. We are happy, but we are not forecasting that COVID is over. We do expect COVID to continue to be with us for a while, but we have the opportunity to get COVID under control. And keep in mind that COVID's not going to go away. It's going to be responsible for respiratory illnesses, and certainly will eventually become, as our state epidemiologist likes to say, the fifth coronavirus that infects people on a periodic basis. And talking about periodic, Dr. Arora, would you like for me to speak just a little bit about flu epidemiology now?
Yes, that would be great.
Sure. And again, as we're getting ready to go into the flu season, and certainly we in the United States and in Alabama, we speak to the flu season as being October to May. But keep in mind that influenza viruses, and I say viruses, there's more than one influenza virus, circulate year-round in the world and even here in the United States. Now, last year, we had far less influenza in Alabama that we have had any time in my fairly long career in public health. And if we look at our overall influenza-like illness, which we define as fever of 100 degrees or greater, and cough or sore throat, or cough and sore throat, again, fever, cough, and or sore throat, in the absence of another more likely cause. And again, if you're talking about ILI, you don't have to have a positive test to consider this to be an influenza-like illness, but we do testing for surveillance in some instances. But again, as part of our surveillance, if we look at our threshold of ILI, in Alabama, we consider a 3.29% to be threshold. And last year in Alabama, we virtually never got there in any level in our state. And a lot of that was related to the fact that at least last year, overall, close to half of Alabamians got their flu vaccine. Again, looking at the entire population that was eligible. And in a good year, we're normally 40% or less, again, overall with influenza vaccine. Now, I do want to point out, just to continue to remind people, because I'm in this age group, persons that are 65 or older just consistently tend to have influenza vaccine rates above 66%. So more than 2/3 of persons in my age group are getting their influenza vaccine. And I think a lot of that relates to the fact that, we remember influenza back before, there was as much widespread use of influenza, as well as recognizing that at one time there were only certain vulnerable age groups or persons that were expected to get flu vaccine. And now we have a broader expectation, and Dr. Stubblefield will speak to that. In Alabama, we do surveillance, obviously year-round, but we have our surveillance maps going up very soon. And this not only looks at our districts, but also gives information related to the type of influenza viruses that we are seeing circulating, and also some very nice graphs on this. Last year, of course, we had a lot of H1N1, a lot of influenza B, some AH1, some AH3. But again, still a very, very low influenza rate in our state. Coupled with that, just a few years ago, I believe it was in 2018, when we had a very significant influenza season, we had 257 deaths that were non-pediatric deaths. We had 93 deaths in 2019 that were non-pediatric deaths. And this past year, we had 22. Okay, we had a low flu season. But again, keep in mind that we've only been reporting adult deaths from influenza since 2018. And both in 18 and 19, we had 2 pediatric deaths respectively. In those 2 years of reporting, we had no pediatric deaths. Last year, pediatric deaths have been reportable in the United States for influenza since about 2005. And also keep in mind that in an average year in Alabama, we may have 10,000 people that we have reported with influenza with ILI, again, as part of our surveillance here. And how many deaths have we had from COVID? We've had maybe 10,000 overall cases of influenza. How many cases have we had of COVID? So we've had a whole lot more cases of COVID, and then certainly a whole lot more deaths in the United States. But again, to go back to 22 deaths reported from influenza last year, as opposed to about 350 if you add the 2 previous years together. And hopefully I didn't garble that too much. But I think the message that I want to really pull together here is that we need to do the same thing for influenza that we're trying to do for COVID, and that is to reduce our ways to contract influenza. One of the most important aspects of that being to vaccinate against influenza. Our influenza vaccine efficacy, again, in a good year, influenza vaccines only about 40 to 60% effective. And people say, well, why should I get that? It's not really that great a vaccine. But we do know that with that 40% to 60% efficacy, if you look at some studies, you're seeing that 75% of ICU admissions in pediatrics, again, it's 75% reduction in pediatric ICU, about 40% reduction in adult hospitalizations, and about 40% reduction in pregnant women being hospitalized. So again, we're decreasing hospitalizations and thereby also decreasing deaths. Let's talk about a few myths before I turn it over to Dr. Stubblefield. I think just a couple of myths that I want to dispel. And one is that if you take the influenza vaccine, that you'll get influenza from the vaccine. Okay, let me just say that doesn't happen. And we can talk about that later if people have more questions about it. In addition to this, I also want to remind people that the statement, well, I'm healthy, I don't need an influenza vaccine. Keep in mind that healthy people have contracted influenza, have become very sick from influenza, have died from influenza. And most notably, you know, as before I turn this over to Dr. Stubblefield, I want to remind people that previously healthy children have contracted influenza and died. So again, we want to do all we can. We're specifically worried about children 5 years of age and under, but again, children can die from influenza even if they're a bit older. And I just don't think that we can say, well, just this few number, because every life is important, every life is precious. So again, I'm healthy, I don't need an influenza vaccine is really a myth that we need to get past. And the final statement that I would like to make is a little bit about allergy and influenza vaccine. Allergy to a vaccine, if you look at AAAAI, and that's a mouthful, but it's a great group to look at when we're talking about allergies, because those are allergists and immunologists together, and they have a lot of resources on their webpage. You know, really maybe 1 in a million or more, 1.3 in a million. So it's very low risk that you're going to have an allergic reaction to a vaccine. And drill that down to influenza, it's probably about the same. Some people are concerned about egg allergy and influenza vaccine. And actually, there are a couple of products that no longer have the ovalbumin in them, so you don't have to worry about egg allergy with those particular vaccines. But again, people who have a history of being allergic to eggs, and keep in mind that's about 1.2% in children and 0.2% in adults, so it's really pretty low. There's current guidance, which I consider to be excellent, and that is that, first of all, if people say, well, I'm egg allergic, but I can eat eggs, okay, well, that's all we need to know. You can eat eggs and you don't have any allergy to happen with that, then, you know, you're good for your influenza vaccine. Certainly want to discuss that with your doctor or your nurse, but, you know, we don't have a restriction on that. Same thing as if you state, well, you know, I ate eggs, but I had hives with it, but, you know, I still eat eggs. Again, you know, you're good for an influenza vaccine. The concern, we have the very rare allergic reactions, which, again, are so rare that I think we need to really consider those to be almost background, but it can happen. It's extremely uncommon, but these are cases if people truly have an anaphylactic reaction. Again, you know, certainly vascular difficulties, vascular collapse, pulmonary problems, wheezing, you know, the gastrointestinal effects that can occur with anaphylaxis. I mean, certainly angioedema. I mean, these are all signs that, again, people are trying to recognize in the medical field, and this would be a contraindication to influenza vaccine if persons had true anaphylaxis. But that's very rare, very uncommon, and we should be discussing that with our doctor if we have a history of anaphylaxis. So we really continue to remind people there are many, many more good reasons to get influenza vaccine, very few contraindications. Certainly if a person has a history of Guillain-Barré 6 weeks after influenza vaccine, that should be discussed with their doctor, because that, you know, might be a reason not to take the influenza vaccine. But overall, the risk of allergy or untoward side effect from influenza vaccine is so rare, and the benefits in terms of reducing severe outcomes are so great that, again, we want to remind people of the extreme importance. Final thing I'd want to say before Dr. Stubblefield speaks is that there's no contraindication to getting your COVID vaccine and your influenza vaccine at the same time. Again, if you're well, let's say, for example, you've had COVID, but your symptoms have resolved, you've completed your isolation period, and you're well, you didn't take monoclonal antibodies, and you now want to go ahead and get your COVID vaccine, which is fine to do. If you took monoclonals, you've got to wait 90 days. But, you know, there's no reason not to get your influenza vaccine, even if you had monoclonals to treat COVID, you can go ahead and get your influenza vaccine, as that's not a reason not to. And just to say a word about monoclonals, we have received a reduction in our monoclonals due to the nationwide allocation, which is based on the last 7 days of hospitalizations as well as the last 7 days of cases. Every state has the same formula to follow here. Our monoclonals this past week, we got 5,276 courses of monoclonals that was mixed between the BAM-EDI and the Regeneron. Again, a certain portion of BAM-EDI and a certain portion of Regeneron. Again, that is a reduction from what we received last week, but we have received a decrease in request for monoclonals. Monoclonals still remain an important therapeutic, but they are not for everyone. They're not recommended for everyone. And we do have information on our website regarding the criteria for monoclonals. So, Dr. Aurora, back to you.
Yeah, no, thank you, Dr. Landers. I think those are some key pieces of information even as our cases are, the trajectory, that was going up is not that way. We still sit at the delicate balance where we're not in a negative hospital situation, but things could change at any given moment. So keeping your flu vaccine in mind, as well as the monoclonal story, those are both really important pieces to have for our landscape in the healthcare world. So I appreciate that information. Dr. Stubblefield, I'm going to go to you. I feel like you have the public health background to discuss, along with just being in practice as a pediatrician. So I'm going to let you share what you want to share now.
Sure. So just a little bit about the flu vaccine itself. So the flu vaccine has been shown to be remarkably safe over time. And I can tell you, in 14 years of practice and 3 years of residency, I don't ever remember seeing any patient have any serious reaction to the flu vaccine. So it is unbelievably rare. And the other good thing is that the flu vaccine works most of the time. Like Dr. Landers said, the formulation of the flu vaccine is in some ways an educated guess made by some very good researchers, because they do have to precede the season in manufacturing so that we can get it before the season starts. The flu vaccine is available in most places now, so we should be able to get those pretty quickly. I've already had mine for this year, so I was excited to get that out of the way. So just a few words about the flu vaccine itself. So the flu vaccine is available pretty much for everyone. If you're 6 months and older, and you can get the flu vaccine, with rare exceptions, like Dr. Landers had said. There are different types of the flu vaccine, but all of the flu vaccines marketed for this year all have the same 4 components in the same 4 strains of protection. They did change the A strains this year. So just a little bit of background information for people. There are 2 major types of influenza that cause most of the disease that we see in humans, is influenza A and influenza B. Influenza A tends to cause most of the epidemics, and influenza B tends to be usually a milder course, but it can also be very serious. You can be infected with either of the strains, and you could potentially be infected with both in the same season. It depends on when they circulate. So the flu vaccine contains 4 components, and again, there are no vaccines that contain anything different, and all vaccines have the same 4 components. So we call that quadrivalent, quad meaning 4. So we have 2 A strains and 2 B strains. The 2 B strains are the same as last year's B strains, but the 2 A strains have changed. The flu vaccine has a remarkable ability to change itself and to try to keep itself infectious. And so, and like our very, very smart Dr. Sag said a few weeks ago on this very call, the virus is always trying to mutate to make itself better. Sometimes it makes mistakes and it makes itself worse, and it doesn't survive, but sometimes it makes mistakes that makes it more infectious or more contagious or more serious. And so we always have to be on the lookout for that. So that's why we put the different strains in there. And so the strains for this year, again, 2 A's and 2 B's. There are really 2 types of vaccine. There's the live attenuated vaccine, which is also, people call it, the brand is called Flu Mist, or the nasal spray. You've heard different people talk about it. It also contains the same 4 ingredients. It's just delivered in a different way. And then there's the inactivated or killed virus vaccine, which is injection. There are different brands of those. And like Dr. Lander said, some of them are made in different ways. Some of them are not made using eggs. Some of them are. It really just depends on what your individual pharmacy or physician orders for this flu season. All of these are made by different companies, but they all should have similar effects, similar side effects, and similar effectiveness in the population. There are some particular caveats about flu vaccine that we should probably mention. It is not available for children under 6 months of age, so that is an excluded population. When it comes to the inactivated vaccine, almost everyone can receive an inactivated vaccine. With a live vaccine, there are some different regulations and stipulations to that, specifically children under 2, adults over 50, pregnant women, those that are immunocompromised. There's an entire list, but if you just put in your favorite search engine, you can put in the brand name and then just put who can get it, and you will find a list, and you can just look to make sure that you're in that eligible population. The good thing being is that it's not an injection, and that we should see similar efficacy to the injection form of the vaccine. There are some other particularly there's one formulation that's given as a high dose flu vaccine to those over 65 years of age. So if you're in that category, you may want to talk to your provider about that specifically. So we've got that I can, just in my years of experience, but 3 years of residency, 14 years of practice, I have never had the flu. I've had the flu vaccine every year. I've had it usually in September. I have never missed a day of work because of influenza. And so I know that it works. And maybe part of this is building, there have been theories out there that maybe we're building this sort of bank of memory by getting all these different types of flu shots, and maybe they're not exactly the same, but maybe there's some cross reactivity. So maybe you're getting some protection, even if we don't get it exactly right. And, and from my circumstance, I've never masked in a practice until this year or 2 years ago. And I saw kids every day with the flu, sometimes hundreds or more in a flu season. And I've been, I've had kids cough in my face and in my eyeballs, and I've never had the flu. So flu vaccine works. It does not make you sick. It does not give you the flu. Now, your body, when you take the flu vaccine, it does mount an immune response. And just like the COVID vaccine, if you had a little sore arm and you didn't feel good for a day, that's your body mounting that immune response. It makes you feel a little puny for a little time, but it's not the flu. It's just the normal way that your body mounts an immune response, makes you feel down a little bit, burns some calories, and then you jump back and you're right back into action. So the biggest thing I would recommend, and I would tell all of my patients this every year, is the flu. I always recommend the flu vaccine. I recommend you get it every year. You get it before the flu season starts. Don't wait until January, February, because historically the flu seasons peak in January, but we have seen them anywhere from September, like we did when H1N1 came out several years ago. And then we've seen them. We've seen double peaks, like we did a few years ago, where we had a couple of different spikes of activity. So the flu can be very bad. And I also want to mention that the possibility of this, people say twindemic. So the possibility of having COVID and flu at the same time, potentially getting very sick. And those chronic medical conditions are really what you need to worry about. So that's all I really had. I just, I wanted to share both my personal experience and the practice experience with you guys.
I think that's really helpful and really reassuring that you have not come down with the flu being a pediatrician for all these years. So that is really good news. Yeah. So I guess a question about should patients get the flu injection in a different arm than they get their COVID injection, or if they're eligible, a booster? In fact, is there anything that y'all recommend in terms of, watching a local reaction, different arm, same arm?
I'd be happy to take that. So there are recommendations about specifically giving this vaccine in separate sites. Separated by at least an inch, but if possible, in separate locations. So in possibility of 2 separate arms, so that you could monitor for reactions and you could know which one caused what reaction. So yes, that is recommended. And those recommendations are on the CDC's website if you're interested in reading them.
Wonderful. And to the people who are nervous about having, additive side effects, if they receive 2 types of injections, and watching for the side effects, would you give them a recommendation to possibly wait and go back a week later, or just?
So the good thing is that there are no minimum intervals between the vaccines. So if someone was particularly interested in giving it a little time between the two because they wanted to wait and see what the side effects would be, that you could do it potentially the next day. There isn't anything you have to wait on in terms of getting one the other, and it really doesn't matter. There are some waiting periods for some very specific vaccines, but those don't have anything to do with the flu.
Perfect. All right. And then I guess back to the monoclonal situation, Dr. Landers, do you have any idea how many people requested and the percentage of requests being fulfilled within this last week?
I don't have the number for this past week specifically. The week before, we did have really about 2 or 3 times the request that we were able to fill with the overall amount that we had. But as we've had a decrease in the overall numbers of cases in Alabama, we've certainly tried to be fair and equitable with our distribution to the sites that were asking for the monoclonals. And again, we specifically asked people to follow the guidance that really outlines, who should receive monoclonals and who might not be eligible. But again, that was the last information I had, which was based upon last week. I do not know about this past week request. I only had the number that we have received.
Okay. And then I know that the public health department came out with, I guess, telling schools to continue to mask in spite of numbers dropping. Any commentary in that regard? I know a few school districts, Dothan, and I forget a few others, have dropped their mask requirements in school. Any commentary on that?
Well, I'll certainly be happy to comment. And then I think Dr. Stubblefield and I, having worked very closely, not only with the pediatric population, but the schools, I'll ask him for his input as well. What I have said to the schools, and again, Dr. Stubblefield and I put out a news release yesterday on this particular subject, is exactly what I spoke about at the very beginning in talking about the COVID update. And that is, we're still in high community transmission. And if you just look at community transmission in the absence of our still high hospitalizations, one other factor that we need to look at very closely in Alabama, I believe it's on tab 8, if anyone's interested in looking at the data, is in this particular part of the pandemic, the pediatric age group, the 0 to 17 age group, has been very significant in its contributions to the numbers of cases of COVID. And in fact, just in the last couple of weeks, our pediatric cases were about 25 to 26% of our cases of COVID. Now our pediatric cases are about 20% of our cases of COVID. So if you look at the 0 to 17 age group and then really break that down to the 5 to 17 age group, probably about 18 or 19% of our previous week, when we were up to about 25, was being driven by the 5 to 17 age group. Keep in mind, as we've talked about before, kids not only can contract COVID and become very sick, but kids can spread COVID, and especially with the more transmissible Delta variant and the higher viral load. So I really urge schools to look at where we are and see that we are going down, but do not stop masking at the moment, because we need to see a sustained decline. And again, part of the reason we've seen less COVID in the schools more recently is schools have used universal masking in many, many systems. And I've looked at data on that, and we have systems that have used universal masking have had less COVID than systems who have not used universal masking. But we have to look at not only what's going on within the school, but also what's going on in the community. And Dr. Stubblefield, again, I know you've worked very hard on this subject. If you might add.
So I agree. It is tempting for all of us when the school districts, when they start to see those numbers going down, and they say to themselves, oh, we only have a few kids out right now with COVID, and we're just not seeing the cases anymore. It's tempting, but just remember that the community transmission is really what we need to be paying attention to. And so I think as we move forward, what we urge the school systems to do is just to hold the course a little bit longer. Let us see the community transmission and the percent positivity continue to drop. We know that most of the kids are, especially in systems where they're masking, the kids are just not getting it at school. They're getting it at home. They're getting it on the weekends and at events. And so it's out there in the community. It still has the potential to spread to other people, to people that can't receive the vaccine, that people that could be very, very sick, pregnant women, grandparents, all the people that we interact with. And so we very much urge the schools just a little bit longer. Just don't, give us a little bit more time before you start relaxing.
I think that's sound advice, and especially it sounds like we'll have a little bit more information on the EUAs for the 5 to 11-year-olds as well. Dr. Landers, do you have any sort of advice with all the confusion out there regarding the booster vaccine? Any sort of words of advice out there? Dr. Stubblefield mentioned, some of the elderly and some of the immunocompromised who fall in the category of being some of the first over 8 months from when they received their first vaccine.
Sure. And again, this has been confusing for everyone, and trying to be able to separate the definitions of booster versus third dose, I think, has been a challenge. So I do want to speak to the issue of third dose, which is still by definition out there. Third dose has been allowed in persons that are immunocompromised or have other certain underlying conditions that might reduce their immune response. And again, third dose has been allowed for a while, both with the Pfizer and the Moderna. So again, third dose is primarily defined as people with immunocompromising conditions or diseases that might lend themselves to a less robust immune response. So there appears to be a little overlap, but I think people have been confused about when booster came along. So again, third dose, if a person took Pfizer or Moderna, if they've completed their primary series by as Dr. Stubblefield pointed out, the minimum interval, which is 3 weeks between Pfizer and 4 weeks between Moderna. What has been stated about third dose is that the third dose can actually be given 28 days after completion of the primary series. And again, this can be done either with the Pfizer product, if that's what the person received initially, or Moderna, if that's what the person received initially. Now, I've had people ask about the mix and match. We do not have approval for mix and match, although there is a statement in the information about third dose that if you cannot discern what product the person received, and that really shouldn't be an issue, because people should either have their vaccine card or the vaccine should be entered in imprint. So just check your imprint and you'll know what product that the person received. So again, third dose has been approved for a while, and I think that's very, very useful in the population we're speaking of. Booster is different, because booster is for people who otherwise would have a better immune system, a more intact immune system, and the ability to respond better to the vaccine. So boosters have actually only been approved for the Pfizer product. So again, if you had Pfizer and you are in the 65 years of age or above, or the 50 and above with certain underlying health conditions, and again, these are spelled out in the information on our website as well as CDC's and in our Health Alert Network, should receive a booster. Again, if you were a Pfizer recipient. Now, you should receive a booster again with Pfizer because you're a Pfizer recipient. Now, in the group that actually there was a lot of discussion, and the CDC director made the decision about persons that are under the 50-year of age group who might have occupational exposures or risk, they may receive a booster. And what that really means is it's really an individual risk assessment in that population. And of course, healthcare workers were in that population, persons who work in grocery and frequent high contact teachers were in that. But again, there's a difference between should and may, whereas should was really where the ACIP came down in terms of this is needed, and then may was the area where the CDC director looked at the information and provided her additional guidance. And there's overlap in all of this, but kind of the final word on this is, what do we do about people who are Moderna and boosters? Well, I'm a Moderna person myself. I took Moderna, so I don't endorse one vaccine or the other. So what am I doing? I'm over 65. Well, I'm waiting for guidance because we followed the scientific guidance all along. I'm waiting for guidance on Moderna. We do not have that for boosters, and I would fall in the category of otherwise being healthy, but being in the age group. Now, what about the J&J people? Again, I also have family members who took J&J. There's not been a recommendation yet for either booster or third dose with J&J. So I remind people that, again, the guidance is not there yet. We do expect more information for Moderna and for J&J. That conversation is going on at this time, but we don't have specific guidance. So again, boosters, I tell people, boosters, Pfizer. If you're not a Pfizer candidate for boosters, just hang on and we'll get the information for you as soon as it's available.
I think that's really helpful in delineating. It can be quite confusing. So any last words before we kind of wrap up? I think y'all covered the flu vaccine really well. I appreciate that. I think that, you know, every year people get confused about when to get it, to hit the peak. You know, everyone starts running to get it, unfortunately too late at a time where they know there's an outbreak. You know, and sometimes we do have the double peaks, you know, so I think, you know, we certainly want to urge everybody to go and get their vaccine now. We're already at the end of September, beginning of October, which is really a great ideal time to get it. So, so anything else that y'all want to add?
I'm sorry, I would just like to thank you for having this. And I also would like to put Dr. Stubblefield on the spot because we didn't really speak to the issue of COVID vaccine between 5 and 11. But again, I would like to ask him to just give a brief comment on the COVID vaccine ages 5 to 11, where we are with that, and just reminding people about not doing off-label. Dr. Stubblefield, I'm sorry to put you on the spot, but you know, I've really tried to utilize you in your new role.
That's a good thing to add. Yes.
That's perfectly fine. So a couple of thoughts that I wanted to mention briefly about COVID. So number one, when Dr. Landers was talking about the Pfizer versus Moderna for the booster, realize that there isn't anything wrong with Moderna. It's just that Pfizer got their information in first. So because we do everything on data, we follow the data very closely. Moderna, from what I understand from a call today, submitted their information at the end of August, and usually it takes 6 to 10 weeks of review before they make any approvals. So we should see something in the next maybe few weeks to month or so, hopefully about Moderna. So again, nothing wrong with that. I'm a Moderna person as well. So to realize that we are counting on studies and data to make these recommendations. I think that's very, very important. Second thing is, we'll continue on the study. The Pfizer vaccine has been studied in a group of children from 5 to 11. These data were, the summary of these data were published on the internet, but they have not released the actual study. So all we have is a press release from Pfizer. We do not have the study results. So I have not been able to read that study. I'm very interested to read it. What we have heard from the study is that the kids at a third of the dose So they, instead of receiving 30 micrograms, they received 10 micrograms. And they're actually studying it even farther down, and those children received an even smaller dose. So, but what they found is that they mounted a very robust immune response, and that their side effects were generally similar to seen in other age groups. So that's what we understand so far. And so we're very excited for this information. We know that 5 to 11 group has been hit very hard by COVID. And if you look at the nationwide data, when the new COVID virus started 20 months ago, it was predominantly an adult disease. We did see some pediatric disease, but if you look over time, that proportion of children has grown and grown, especially with the Delta variant. So we're and particularly that 5 to 11 group is a lot of those cases. So we're very excited to see this 5 to 11 group. Remember, anything 12 and up is covered under the emergency use authorization. So your children can be vaccinated with the Pfizer product. 12 and up, again, only on data, because Moderna, again, we didn't have the information, so they can't make a recommendation. And it is FDA approved for 16 and up. So have FDA approval, which the EUA approval precedes FDA approval, again, having to go through more data. So we have availability for 12 and up, and we have and then we have the FDA approval for 16 and up. And hopefully within the next weeks to months, we'll see something about this 5 to 11.
I think that, yeah, that sounds very promising. Do you have any feedback in terms of, in your practice, Dr. Stubblefield, long COVID with your pediatric patients?
So, honestly, we did see some long COVID in our pediatric patients. We saw a variety of different symptoms that were persistent for different ages. We didn't really see anything specific or anything that was that we could particularly say, oh, this is something we're seeing a lot in children. It seems to be all over the board, kind of like it does in adults. Even in my own family, we have some of my family members have some long COVID symptoms, but they're all a little bit different. So in children, we know that they get long COVID. We know that they can have other manifestations, other long-term problems, both from the virus attacking certain organ systems, but then some of the other symptoms, the smell, the mental fogginess, some of the other things that adults have complained of as well.
Right.
And don't forget, I always try to mention this, but this very, very serious condition called MASA, you may have seen in the news, it is very serious. It follows COVID infection by 4 to 6 weeks. We don't really understand a lot about it, but it is a potentially fatal syndrome, and we know that it's vaccine preventable. So it is not seen after a vaccine, but it is seen after infection. It might be that the Delta variant isn't quite as likely to cause this. We haven't seen that big spike, but we also are not quite 6 weeks out from our big spike in Delta either. So we could start seeing some MISC cases, but don't forget about that. It is very serious, and it is heartbreaking for these families.
Yeah, that is good to remind us about that. I guess there were a couple of questions that came in, one in specifics to ball games that have been taking place, in the outdoor environment with large groups. And no significant rises in positivity following these ball games. Any commentary on that?
Well, I'll take that one, just because I think when we're talking about outside in general, if we think about the virus and we think about the effect that wind currents and the effect of desiccation depending on the temperature, we just think overall about respiratory droplets, and outside we probably have less transmission anyway, even with the Delta variant. However, and again, I want to continue to echo some very smart people that I've heard speak from the various universities. If you are in a situation where you're jammed up next to one another and you have very small levels of space between one another, and certainly even if you are vaccinated, I would be cautious. I would just be cautious. I don't necessarily want people in my space. And I still like 3 feet of distance. I mean, I'm just one of these people that likes a lot of space. So I would be cautious. But again, I do think outdoor transmission overall has not been seen as much in COVID. And I do think that we can feel better about outdoor activities, but just a word of caution, if you are attending something that you are so closely packed together, you can't really have some comfortable space between people. Certainly assess your own potential individual risk if you're not vaccinated, but also be aware of your own health history. You know, even if you're vaccinated and you are a more vulnerable person in terms of your immunity, you know, if it were me, I would be wearing a mask, but I know nothing about football. So,
and then one more question on, as people are now starting to get the flu shot, has the ADPH, have people started to see people getting their first COVID shot along with their flu shot? Are we starting to see a little bit of a rise in our capture?
Wes, do you want to take that? I think you've probably heard some people speak to it. I have heard some people, and we've had some people that have been taking both vaccines, and you know, certainly hasn't been an issue. I don't expect an issue. Wes, do you have anything on that?
I don't. I really haven't heard anything about that specifically. You know, our vaccine uptake almost exactly mirrors the extent of disease. People tend to get the vaccine when the disease is rampant, and I think it has to do with maybe family and friends getting sick or news stories. So we have seen a pretty good drop off in the number of people getting their COVID vaccine as the disease has started to slow down a little bit. So again, stay vigilant. You know, I wanted to go back and talk just briefly about the football game. You know, I went to a football game for my nephew the other night, and I think I was one of the only people with a mask on. But you know, that's that individual right, and I think we need to make good decisions for ourselves and for our community. And like Dr. Landers said, you just evaluate the risk, and especially if you're unvaccinated, and make that decision for yourself. But you know, I think the main thing is us all being good to each other and getting through this together.
100%. I agree. I think that last comment is an important one. So hopefully we can all do that. Well, I thank both of you so much for your time and your expertise and your wonderful communication today on some important messaging. So thank you for doing this, and we appreciate everything both of you do with the Public Health Department.
Thank you.
Thank you so much for having us.
Absolutely.